Good morning, everyone. Welcome to the UBC Learning Circle, hosted by the Center for Excellence in Indigenous Health. We are very pleased today to have Robin and Tracy join us to chat with us about their Rehab Support Skills program. Did I get that one right?
Yeah.
Okay. And also we'll have a participant join us sometime during the session to share her experiences. Before we begin, I would like to acknowledge that we are on the traditional, ancestral, and unceded territories of the Hunkaminam-speaking Musqueam people. I would also like to acknowledge the First Nations Health Authority for generously funding the UBC Learning Circle. So, brief introductions before we kind of slide into it. My name is Cole. I'm from the Chewotho First Nation. I'll be facilitating the session today, so I'll be asking a few questions and facilitating any of the questions that you have. Yeah, that's kind of my role. Other Learning Circle team members in the room today, but off camera, are Cynthia, our production coordinator, and Kaylin, our program assistant. So, again, and just a last kind of trigger warning here. If for whatever reason, the topics we cover they can be sensitive or they can be emotionally triggering, and sometimes the topics that we're going to talk about today could be that for you. So if that's you, please make sure that you're investing in a support system of some kind, whether or not that's an elder or a family member, a counselor, or anything that you need. Please make sure that those support services are available. So with that, I think I'm going to kind of stop talking for a little while. Would you guys mind introducing yourselves before we begin?
Sure. My name is Tracy Dignum. I'm a physiotherapist, and I am coordinator of the Rehabilitation Assistant Diploma Program at Capilano University.
And I'm Robin Roots. I'm a physiotherapist as well and an instructor in the Department of Physical Therapy here at UBC.
Great. Cool. So to begin, why don't, Robin, you tell us a little bit about your role as a physiotherapist and as an educator within the context of this project.
Thanks, Cole. It's a great honor to be here today, so thank you. And my role is as a physiotherapist. I've worked in rural, remote, and northern communities my whole career, starting on the north end of Vancouver Island with the Kwakwaka'wakw people, and then further up the coast on the northwest coast near Prince Rupert. And my current role is as an instructor in the Department of Physical Therapy, where I teach students in the clinical setting, and that involves doing some work with Sekani Family Services as part of their primary care team, and in an effort to provide physiotherapy services to many of the underserviced communities in the Carrier region. I take students out on clinical placements, like this picture here. We go to Stilatin, Notley, Takla, and Yukuche, and give students an opportunity to really understand what physiotherapy practice can look like in remote communities, to also have an opportunity to learn about culturally safe care and what it means to provide trauma-informed practice. So that's a big part of my role as a clinician and as an instructor now.
Great, thanks, Robin. So this sounds awesome. Can you maybe walk us through some of the challenges that you've encountered while delivering these rehabilitation services?
Yeah, absolutely. I think that like many remote communities, access to rehabilitation services is enormously challenging. Perhaps just for our listeners today to be reminded that rehabilitation services often includes the services of a physiotherapist and of an occupational therapist. And physiotherapy is a profession that works with individuals who've had injuries, disabilities, or illness that cause some kind of physical limitation. Particularly that might be mobility, but it might also be in terms of their strength or movement or balance or maybe even cardiovascular fitness. And so physiotherapists work with those individuals to try and optimize their movement. Occupational therapists, who also falls under that kind of bracket of rehabilitation services, work with individuals to problem solve how to reintegrate back to occupation. So that occupation could be their work, or it could be day-to-day activities like self-care, or activities like going fishing, those kinds of things. So occupational therapists work with those individuals to try and help them be able to go back to day-to-day activities. So access to physiotherapists and occupational therapists, the challenges are many. Like many medical services, remote communities and residents in those remote communities have to travel long distance to access those services. And then if and when they do, there are financial barriers, particularly rehab services do not fall under non-insured health benefits. Equipment does, but actually the services provided by OTs or PTs is not covered by NHB. Medical services plan doesn't cover very much of those services either. So there's a real financial barrier as well. And if you were to access services within the public system, I think there's also a real dearth of culturally appropriate, relevant, trauma-informed care that people can access. So those barriers are many. In communities like Takla that we go to, it's a 5-hour drive to the nearest physiotherapist or occupational therapist. And so that's a long way if you have an injury, if you have an elder who's had a stroke and who may have been transferred to a place like Prince George for acute medical services, and now is returning to those communities and may have difficulty actually moving about, whereas an occupational therapist and a physiotherapist might actually be able to help that individual have a better quality of life by being able to actually move around the home, move around the community, go back to being able to do activities that are meaningful to them. So there's a real challenge in terms of the way in which we currently provide rehab services to most people who live in communities.
Mm-hmm. While I have you here, do you know if the new kind of benefits coverage plan from FNHA will cover the physiotherapists or the occupational therapists?
There's better funding for transportation to those services now, which is a big benefit for sure. So we're seeing that, but the actual availability of services and the access to services and then the coverage of that is still very limited. So currently there are very few OTs or PTs who are employed by FNHA, and so and that would definitely help the system. So yeah, hopefully we'll get there.
Great. So what do you think, in your opinion, after these experiences would be the ideal model to provide rehab services in these kind of more remote communities?
I think what we can learn from other places around the world, particularly remote communities and many remote Indigenous communities, is a model whereby we train folks in the community locally to be able to carry out the rehab services that an occupational therapist or physiotherapist would have prescribed or have done an assessment and determine what the best treatment for them is, and then have those folks that are situated locally be able to deliver the service. I think we need to really think about ways in which we can build that capacity to have individuals that are there that understand the community, understand the needs of the community, and be able to provide it. So I think we're looking around the world, that's called community-based rehabilitation, and there's lots of different models about the training associated with community-based rehabilitation.
So to be clear then, we're talking about building capacity within community members to execute the exercises, not necessarily to diagnose or prescribe the exercises?
Right.
Okay.
That's right.
Right.
So in a case, where they can then be there on a day-to-day basis, models such as what I'm doing right now with students to these 4 communities, we're there once every 2 months. And so it's wonderful to be able to at least provide that, but we're not there every day. And folks who, for instance, might have had a stroke would actually need daily rehabilitation services in order to really reach their maximal potential. Yeah.
Great. Thanks, Robin. So I think switching gears over, Tracy, Can you tell me a little bit about your role as a physiotherapist and educator?
Sure. So my perspective is that I teach and coordinate the rehab assistant program at Capilano. So I'm accustomed to the model of service delivery that we've developed, which is a really good one for rehab service delivery in the Lower Mainland. What it essentially means is we've got lots of rehab assistants that are trained, that are really competent in carrying out these clinical, technical, operational skills. So they're working under indirect or direct supervision of physios and OTs. So it's working really nicely down here. But the problem is, we don't have students that are receiving that education that are in the north or in many parts of the province. There's only 3 programs and 2 of them are in Vancouver. So what we've started to think about is how could we get creative? And we've tried partnering with practicum sites in more remote communities, which the students really enjoy, but they don't tend to go back to. So getting creative along the line of what Robin was talking about, we thought, wouldn't it be nice if we really could deliver the education in the home communities where these folks are, and make sure that it's appropriate. It's not the same sort of urban big hospital model.
Right.
So Robin and I had been chatting about this informally for, I don't know, on and off for a while. And then there was a call for a grant opportunity with the Ministry of Advanced Education. And so it was for a one-time delivery of a short duration, so under a year, health education program to meet health human resources needs. And it was meant to be in a community that couldn't sustain it long term, but that a one-time go would really have an impact. So we thought, wow, this fits with what we were thinking of. Timelines were tight. So applied sort of November, December, found out we got it in mid-February, and we were meant to have stable enrollment by March 11th, which was really, really quick. This was a couple of years ago. So, you know, the first challenge for us was we had to recruit students. And so we initially had thought if we wanted to find folks that were already in the communities, already working in health service provision roles, we thought healthcare assistant training was what we were looking for. And so that's who we initially intended to recruit, and we'd partnered with Sekani Family Services, and they were really supportive of that. But when it actually came time for recruitment, due to a lot of factors and mostly just due to time, we realized that to get the numbers we were going to need to open it up a little bit. So looking at this photo of our students, we have students that were healthcare assistants, 3 of them. 3 of them were early childhood educators, which wasn't something we expected. They came in with their pediatric training, which turned out to be actually a great thing. And then we have a nurse, community health nurse as well, who took the program. So that was the first step, was rounding up the students that were interested in taking it, were willing to take this on in addition to their job. They were given the time off, but were still maintaining their employment as well. So then we took the 2-year diploma standard curriculum and we adapted it down to a 1-year program. And this slide captures what the courses were. There were 5 courses and a practicum, and we needed to fit those in across the year. So essentially what we taught them was, first of all, what is rehab? Because if you come from a nursing perspective, it's quite different. We're teaching them to have the abilities to mentor, coach, motivate people to be independent. We're not care providers. So it's quite a different lens. So that was important, and that's what that 100 level course was. Because we were working within the post-secondary sort of credential requirements, we needed to have a communications course to grant a certificate. So that was very specific to rehab. So it was therapeutic communication, and that proved to be well received, and that also is where they learned how to document. And then we had specific context, so a musculoskeletal. So this is where they'd learn about fractures, joint replacements, soft tissue injuries, strains, sprains, neurological disease, injury and intervention. So this is strokes, brain injuries, a little bit about spinal cord injury, some developmental delay on the pediatric side of things. Then we got into the specific populations. So for that one, we had 2 different instructors. We had an instructor come from Vancouver Coastal Health who was very knowledgeable about older adults, And then we had an instructor who's a physiotherapist working up in the north, and she is very knowledgeable about pediatrics. And so we were able to spread it across the two. So they got a really nice, well-rounded, balanced sense of rehab and the theory, but what we really were trying to do was give them skills. So before they went out on practicum, they needed to have all these skills. So I'll flip through a few photos here just to give you a little sense. The curriculum was delivered in two places, in Vanderhoof and in Stellaton. So this is a picture in Vanderhoof during one of the first courses. And so, wherever we were making sure that we were trying to bring in those concepts, the body mechanics, the exercise principles, the why of why we were doing some of these exercises and movements. They're doing some neck range of motion exercises. And, for a lot of these folks, they were already kind of doing very similar in their job. They were going into homes, they were helping them out with injuries and such, but getting to see it from a rehab perspective, they'd say, oh, okay, so this is why you think it's important. Or, we were just kind of giving them that different way of viewing some of what they were already doing. And for some of them, it was really new. So, if they were used to working in pediatrics, then thinking about strengthening lower extremities so someone could get out of a chair wasn't necessarily what they were accustomed to learning. But they were all really keen. We were very lucky. We had really keen, bright students. And so they brought a lot to us as well. Like, I wouldn't discount how much I learned as well. For me in particular, because I wasn't accustomed to sort of these communities and the challenges of service delivery in some of these smaller places, I was really impressed with the creativity and sort of, the open-mindedness of the students and what they brought to the class. So here's some more exercise ones. Here's when we were in Stellaton. Beautiful facility, so that was really nice. They did have some written assignments as well. We wanted them to be able to document, because in the model, when you have support workers in rehab and when you have therapists that are coming and going perhaps infrequently, it's very important that the communication is in place there. So we need to make sure that it's not just verbal, but that they were actually documenting in the clinical record appropriately in terms of, what had been carried out and what were the findings. And we wanted to make sure that skills that, for instance, transfers, healthcare assistants are very competent at them. But they might see them as, that's how I get them out of bed so I can take them to the shower. And we were trying to teach them, let's step back in terms of how you do it, so that the patient, the client's going to have to do a little bit more, and they're going to have to work at being more and more independent. So you're not just taking care of them and getting them into the chair. You're going to try to train them so that they can potentially one day transfer on their own. So I think it was nice for them to see it that way. We had to assess their learning, and so we wanted that to be really practical. They did have some written quizzes, but mostly it was practical. So this next slide shows a rubric for a practical test. We kept it pretty low key. We did it as a group. We're able to sort of share feedback. Again, they were such great learners. They didn't mind being put on the spot. They liked it. And so, we sort of kept a fairly structured rubric because we did want that professionalism piece. We wanted to see that they weren't going to injure themselves over time. So that's why we have the body mechanics in there and the safety. And then just making sure that they knew all of the components of completing the task. So they were getting some feedback on all of those. And then for every course, we created these skills checklists. And so whether it was for the neurological skills, the orthopedic skills, they could see at the beginning of the course, oh, this is what I'm going to learn. And it was a lot. And then they could say, okay, I'm going to tackle these ones today. Or, can I show you, Robin, how I'm doing on, teaching these isometric exercises and such. And so I should be clear that it wasn't just that they knew how to do them. They had to be able to teach them. So much of rehab is teaching. And so they had to demonstrate that they could explain how to carry these out. So that was the other way that we assessed their knowledge, their skills, their competence. And then the other way we did it was when they were on practicum, we had these tracking tools. So we came up with the template that allowed them to track the individual skills that they did, and a little bit about the individual while keeping it all confidential. And then practice documenting a little bit. So you can see the subjective, the objective information they collected. They're talking about what task they actually did, and then the plan in there as well. So we were trying to mimic a little bit of the clinical record in that. So that's how we delivered it. The format of the program was, we didn't want to disrupt Carrier Sekani's, health service delivery. So we had to schedule the courses quite far in advance, 4 to 6 months in advance.
Wow.
And we then had to look at, everybody's work schedule, difficult to run a class on a Monday or a Friday because they didn't want to leave patients for too long without their service providers.
Mm-hmm.
And so that part of it was tricky, but we would do sort of 2 days back to back. It was costly. Luckily, we had that grant because we had to fly instructors. 2 of our instructors came up from Vancouver.
Mm-hmm.
One was Capilano, and then me, Capilano, and one was Vancouver Coastal Health. And then we had a Carrier Sekani occupational therapist, Robin, and a physio that works in the north. So they had a good balance, I think, of different instructors to keep it interesting.
Mm-hmm.
And in terms of equipment, Robin had access to her materials in Prince George, so we were able to bring a lot of equipment for them to use. But we didn't do any online learning. We gave them a lot of paper materials, but it was all sort of live, in-class, practical sessions for the course of the day.
Mm-hmm.
So I think that's probably as much as I need to explain about delivery. If you want to speak a bit about practicum, Robin, do you want to take it from there a little bit about how we did that?
Sure. So as Tracy mentioned, the very last sort of course in this certificate program was a practicum where we really wanted participants and students to actually utilize the skills with clients in a way that we could provide some feedback and actually help them really integrate what they learned in the classroom back into the day-to-day world of looking after patients. And one of the things that we noticed with this practicum, which was designed to be carried out in their normal workday and just have either the OT or myself supervise them and just do what we had expected for that particular model of service, which was the OT or PT would have already assessed the patient and determined this is what kind of rehab activity the client needed,
Mm-hmm.
and then we would ask the care aide or the early childhood educator, whoever was working with the client, to actually carry that program out. And one of the things that we noticed right off the bat was that they didn't have the equipment accessible in communities. And the other was they really needed an exercise booklet to be able to kind of show which those exercises were. So we had one of Tracy's rehab assistant students down in Capilano actually take that on as a project to then give back to the community. So they made up a really great booklet, which we gave to each community health center and to each of the care aides or participants in the program. And it had really detailed pictures of the exercises that they would be doing with patients. It also had some information about mobility aids, how to measure for wheelchair, all things that they had learned in the program, but was in a nice, neat form booklet that they could actually have in the community and would also stay with the community. So that, again, with a sort of idea that in the long run we wanted to really build capacity for the community to be able to carry that out. We also put together kits for each of the health centers, which had the equipment that the participants in the program who had learned all these skills would use on a regular basis. So there were hand weights and ankle and wrist cuff weights, objects such as elasticized shoelaces, which would be really useful for working with a client, or foam padding to be able to use around utensils or other objects to increase grip, and all the sorts of small items that OTs and PTs use on a regular basis kind of in the community. So with having each health center having one of these kits now, it was much easier for the students from the graduates from the program to be able to actually carry that out. I think we also learned in that process of the practicum that there were some challenges with being able to actually carry out some of the skills that we had been instructing the participants with. Some of that I think had to do with they were adding this in an already busy job, where for the home support workers they would already be bathing clients and looking after the personal needs of the clients, and now we're asking them to also do rehab services or rehab activities with them. So we learned a little bit through that process, and that made us think about the need to possibly come back together after the participants had been out working for about 4 months. We brought them all together again. Do you want to speak to that, Tracy?
Mm-hmm. Yeah, so when we were developing the curriculum, we really were trying to think about how we would optimize it for service delivery. How would we... Our whole intention wasn't just to give them a bunch of knowledge. It was actually to make sure that they're going to be able to use these skills and that they would be able to provide services to these communities. But there were just so many aspects to consider with it. And one of the considerations that I think maybe I hadn't realized enough was that we were taking students that already have full-time jobs, already have full caseloads, and then we were giving them these new skills and hoping that they could add them in. And really the idea would be to have students that were able to adopt these new roles in their own time, not just on top of their existing job. So I think what happened was a little bit of just out of them being busy and out of them not always being of the mindset that they could start using these skills. Some of it wasn't being used the way we'd hoped. And so Robin talked to some folks at Sekani. We decided it'd be a good idea to do a refresher session. And what we did was we came up with some actual case studies of very specific, tangible types of patients. This individual's had a hip fracture. They've come back to the community with these restrictions in weight bearing and range of motion, this limitation in their strength and their function. What kind of tasks might they need to improve their outcomes? And so then we had these protocols developed that would answer those. We would be able to say, this would be the protocol that you could use with this type of individual. And so when we brought them back together in Prince George, they already had all those skills. They just hadn't maybe clustered them together that way. So then we had them practice it. And we did have a case manager from Sekani come and observe that, so she could say, oh, wow, okay, they know how to do all that. And yeah, that makes sense. And they're already going to see that person to help them with their dressing. So while they're there, they could do protocol 1 with that individual. So I think if we were to do this again, we might work backwards a little bit, and we would talk to the community and sort of find out what their anticipated health needs would be, figure out those protocols, and then work backwards on the curriculum instead of taking the existing kind of the framework is for the 2-year training for urban, credentialed rehab assistants and modifying it. It worked well what we did, but we ended up having to do that extra session to loop back.
Mm-hmm.
Yeah.
I have a few questions. The first one being very straightforward. Where did the resource kit stuff come from?
Amazon. No, well, it did. I actually can't believe they delivered so many weights. But we had the funding from the ministry, and we were permitted. We couldn't buy equipment that would be for Capilano or for UBC, but we could buy teaching materials. And so we got permission from the ministry to purchase the equipment. So, we spent part of our budget on that. And got quite a few items. We also got some resources that aren't in the kits that were things like reachers, long-handed reachers, sock aids, dressing things that were sort of teaching materials that we used in the teaching, but then we also left them so that if we were to run a similar program, we have those teaching materials as well.
Yeah, so those are we've often used in at some of the health fairs that each of the communities have sort of once or twice a year to actually help increase people's awareness of what rehabilitation services are, so that they can see that, oh, if I'm struggling with putting my socks on, there actually is a tool to help me with that. Things that people may never have had the opportunity to even know about. So we've done a lot of work kind of in conjunction with this program to just actually raise awareness and education about what's available for in terms of rehabilitation.
And with respect to equipment, another thing that I think was a big value add was simply knowing how to adjust equipment. Because, and maybe it's because of the funding model, that there often may be equipment in place that there isn't training coming with the equipment. And so it can be quite detrimental for someone to be using crutches that are too high, or a walker that's too low, or equipment that's not safely being used. So our students a few times said, and that was some of the feedback we got, was, wow, it was so great to know the ins and outs of how to adjust the canes, the crutches, the walkers, that sort of thing.
Yeah. Well, it's critical, right? Making sure the proper rehab happens. I do have a question regarding the follow-up session, I suppose. You mentioned that, Robin, you went and chatted with somebody from Carrier Sekani. I just wanted to know kind of how much of your work from that point, right? Like, you deliver the curriculum, deliver the practicum, we step back and we say, okay, maybe these skills aren't being used as much as we had anticipated. How much of that work from that point on was done in conjunction with community leaders, either from the health departments themselves, or broadly, like from elders or other kind of community-based leaders, I suppose? How much input did they have in designing what that follow-up looked like?
Yeah, great question. So we worked quite closely with the nursing manager from Carrier Sekani Family Services, who oversees all of these roles, and had a good sense and was getting feedback from both the students in the program, but also from the clients in the community about the use of the skills. And so that, I think, is what was a big prompt to us to do this refresher program. And then we worked quite closely and involved the nurses in community and the nurse manager in that refresher session, so they could actually see the participants, the care aides and the early childhood educators actually using the skills, so that having other members of the healthcare team know what skills these individuals had meant that then there's going to be greater uptake and better understanding of the use of that. So I think that, again, as Tracy said, was sort of a lesson that we learned at the end, that we could have done more at the beginning to implement them. And then I think that sort of then kind of feeds into some of the feedback and evaluation that we did of the program at that point. We then asked participants to give us some feedback. We interviewed some of the other members of the team, some of the instructors, and really tried to see what we learned in that. Yeah.
Should I speak to the feedback a little bit? Sure. So we did questionnaires, anonymous questionnaires with the students, but we also interviewed them, and they were really transparent about their feedback, so that was really helpful, and probably we were able to identify really 4 themes that we would address if we were ever given the privilege of doing this again. The first thing was recruitment. We were, as I explained earlier, we had a really tight timeline, so I think being very intentional about recruitment, so connecting with community partners, connecting with healthcare teams, potentially linking neighborhood communities or joining, doing some sort of partnerships so that you could have larger numbers might have been helpful. But simply just having a little bit more time to be intentional in that. Having said that, though, like I mentioned, we did end up with some early childhood educators. We were looking for health paraprofessionals, so we sort of at first went, I don't know if that's the right fit. They were great because they came with a wealth of knowledge about, developmental delay and some of the pediatric challenges that they were seeing. And they also said, it doesn't matter that I work in pediatrics. Within my community, I'm able to use this with family members, with friends, with relatives. It's all really relevant, and we're all aging, so it's all useful. So their feedback was pretty good that the students we did have were appropriate, but I think we could have had more if we'd been a little more intentional. So recruitment was the first one. The second was retention, and life happens. So we had very motivated students. It wasn't that was the issue, but we had three things happen. One person got injured, had an illness and was on a medical leave. And because this was offered through employment, they couldn't very well come to our course when they weren't able to come to work. So she took part of the program, but just didn't get the certificate at the end. One student changed jobs. So same thing, it was linked to her employment, so she took part but didn't finish. But the third one I think was the most telling, is that simply the demands of her health service delivery job made it too hard for her to be consistent. So she was there throughout the entire program, but she'd miss pieces of it because sometimes we were teaching right where she worked, and she would think, I have to go see that resident or that client. So unfortunately, she missed too much to complete the program, but she was a great sport, learned everything she could learn from it. But I think that kind of talks to the next point, which is service delivery, or which is program delivery. We should have done modules or some form of online curriculum that would have allowed people like her to make up content. Because what we realized is as soon as someone was sick or missed something, this is so hands-on, and I see this in my Capilano program as well, it's very hard to catch people up. You have to have really tight attendance policies. So we could have bridged that better if we'd had some online. And we initially, very brief environmental scan told us, oh no, this is practical, you shouldn't be doing anything online, better to do face-to-face. But pretty much every student said it would have been great to have online. Why don't you do online modules for the theory with videos and then bring us together for the practical sessions? And I think that'd be great because you could actually have this offered in multiple communities where everybody's doing these online modules at their own pace, right? And if life got in the way, they could get caught up. And you could have built-in quizzes to sort of ensure competence or sort of knowledge base before you came to the practicals. But then you could bring people together to a central location and do intensive practical labs and practical testing. And that's pretty much what the students told us. So they enjoyed what we did. They enjoyed having multiple instructors. Although they appreciated that either Robin or me, that one of us tended to always be there. For that consistency. It was expensive the way we did it because, people flying up, traveling, driving, bringing materials. But I think we needed that for first go around just to get a really good sense of the two-way learning that was going on. I think program delivery, we would have kept similar time frame. We did it over the course of a year. It went from June to May, with a course offered in June, 2 in the fall, so then a January, a March, and the practicum was done by sort of April, May. I can't really imagine doing it much faster than that, but I also believe that the more you condense things, the sort of, I think, better buy-in there is and better consistency in sort of commitment and learning. So again, that online or that mixed mode way might have approached that better. And then the final piece we've already spoken to a little bit, which is service delivery, is that we were thinking, I'm an educator, I'm a physio as well, and I went to Nunavut years ago and tried to help them with training of their support personnel, and they have an incredibly challenging situation. They use a lot of telerehab. They have OTs and physios from across the country that are working there, so they've got different regulatory bodies and sort of training and expectations. And then they have challenging geography, lots of dialects, and so for them, trying to deliver rehab services are really, really tough. But I worked with Arctic College, and we trained they had trained a cohort of assistants, and then I came up there and tried to help them a little bit. And that, at least I came into this with my eyes open as to how hard this was to do, because geography just makes things a lot harder. And so I think I saw even more by the end of this program, though, that programs maybe have to start with looking at the community, talking to the stakeholders, really getting a strong sense of what they want out of it. And Sekani did that for us initially. It's not that we didn't get that from them, but I think on a personal level, I now realize that I would have really liked to do a sound environmental scan, so that I felt like our curriculum was bang on for what they were needing. And then I think that would have resulted in better uptake of the actual skills. In the end, we looped back, and I think we got there. But next time, I think the trick is to start in the communities and get a real sense of what they need.
So kind of coming back around to recruitment, for me, this just might be an ignorant question, and if so, I apologize. Why were you only targeting individuals that already worked in healthcare? Is it because of their background knowledge?
Yeah, good question. The typical standard for rehab assistants in Canada is 2 years. It's a 2-year diploma, but they don't have any health background. They might, but they don't need any. You know, the prerequisite might be a Science 12, right? Yeah. So that's the typical standard. And we recognized that wasn't realistic. And, they're not regulated, so we didn't have to stick to that. It's considered, the best practice and the accreditation standard that Canadian associations of OT and physio adhere to. Yeah. But we knew we didn't have to do that. But we thought, okay, if we're cutting it down by a year, we need to assume they've got medical terminology, they've got anatomy, physiology, they've got an understanding of disease processes. We really needed them to have that foundation. But this could be delivered to people from other backgrounds if there was a bit of a bridge. If they had, a foundational couple of courses that they could get those pieces that they're missing. But healthcare assistants have, a very rigorous program in terms of their knowledge of infection control, body mechanics, lifting techniques, all of those care skills that they have. So we thought if they already have that, we can just load them with rehab skills. Like that was kind of our dream.
Yeah, of course.
But you're right, we could, a lot of this, people from other backgrounds for sure would be, people with educational backgrounds. A lot of this is teaching, right? Anyone that's got strong linkages to the community that could really... Because I find as a physio, some of my job is sales. I have to convince someone that they want to get stronger. Or I have to convince them that if they improve their balance, they'll fall less. So it's worth working on balance rather than, I'm scared I'm going to fall, so I'm just going to stay sitting in this chair. So a lot of it's motivating people and teaching them. So you can think of different, skill sets, professions that would be great.
Yeah.
For that,
Yeah. I think just like kind of listening to some of your guys' feedback, it occurred to me that within community, particularly within more isolated or rural communities, there tends to be champions that take on a lot of this work.
Yeah.
And then with this like fantastic program, and I love the idea, but it seems like we're loading, or we seem to be loading the same people, and it would be really great to see that capacity spread out a little bit more within the community, which I'm sure is something that we were thinking about.
I would love to see a hybrid program that would be the healthcare assistant and the rehab assistant blended, so that you could train people, and it would be with the lens of community. And so that way they would come out, if they didn't start with any background, that they would actually come out really well-rounded. Oh, and I think this is our call from our participant.
There we go. Hi, Dawne.
Hi.
Hi, it's Cole here. Robin and Trace here in the room as well. You're on speakerphone. How are you?
Good. How are you doing?
I'm doing quite well.
Hi, Dawne.
Hi, Dawne.
Hello.
We know you've got a limited amount of time, so I'll just jump right into it. For all of us individuals that are listening at home, can you maybe introduce yourself and your relation to the program quickly?
Yep. So I'm Dawne Persson. I currently work for Sekani Family Services. I do the director of their early childhood development programs. I took this course a couple years ago now through Sekani, and it was on a part-time basis, and really enjoyed it.
Fantastic. So, kind of going off that vein, as a student in the program, can you share a little bit more about your experiences? Maybe like why did you decide to participate to begin with?
Sure. Yep. So mainly I decided to take the training as majority of my programs are working with children 0 to 6 years of age. And under one of my programs, we do have physiotherapy and occupational therapy services. However, a lot of those, we're trying to service such a massive geographical area. So a lot of the times, the frontline workers are doing a lot of that kind of follow-up therapy. So our occupational physios go in, do initial assessments and stuff, and then frontline workers are left to kind of do the follow-up. And as manager of the program, it was helpful for me to take the program just to be able to guide them a little bit better. And in some cases, I do end up working one-on-one with some of the more high-risk kids. So those were basically my main reasons.
Great. Awesome. And you mentioned it was part-time. You really enjoyed the program. Can you tell us a little bit more about what it was like to be a participant? It was a small class size, and you guys had different sites.
Yeah, the small class size was great because it was more interactive. I really liked the fact that you could fit it into, like, you're working full-time, but be doing it on a part-time basis. It was doable to be able to leave my office kind of thing, attend. We had it in a health station, and then work with different colleagues and stuff about things. I really liked the combination of there was reading and PowerPoint, but also after all that reading PowerPoints kind of things is you actually got to do like the hands-on learning, which is a huge benefit, and being able to like actually practice your skills and doing that with each other. And they would bring in other instructors and stuff like that. So some of the time we had like a physiotherapist come in and they would show us different techniques, or an occupational therapist come in, as well as the main instructors for it. So it was just that combination of everything that really made the program successful for learners.
Great. That kind of answered my next part of the question, but so I was going to ask you what did you like about the program, but I think we kind of went over that one. Is there anything else that you wanted to add? Anything else that really stood out to you?
I think the main things I kind of already said. One thing I think that can kind of be, expanded in the program.
Yeah, absolutely.
Is a little bit more focused on like the younger children. A lot of the program was focused more on like the adults and teens kind of thing. There were portions of the modules that touched on like the younger, that 0 to kind of 8 range. But I definitely could see areas of where that could be expanded out a little bit more.
Great. Yeah. And I think we were kind of having a conversation a little bit more, perhaps starting somewhere in the community to contextualize what it is that we need to focus on within each different community or region could help to further contextualize that curriculum. I think that's kind of something we've been talking about before you jumped on the phone here. So thanks for that feedback, Dawne.
Yeah, no problem.
So my last question, how did completing the program help you? Like, how do you think it helped your team, and what would you like to see in the future specifically?
So as far as my team, it's really helped them be able to work side by side with the occupational therapists and physiotherapists. And even the ones, like we have ones directly on our team, but there's also the external ones that come into the schools and stuff when we end up working with those kids. It really helped be able to, like, if you're taking plans from them and stuff, is being able to implement those plans better and have more in-depth conversations because they had a better understanding of things. And also knowing where do I access these resources, and that these resources are out there to ask for. So just expanding that area.
Great. Awesome. Thank you very much, Dawn. I appreciate it.
No problem.
Robin, Tracy, did you guys have anything that you wanted to ask Dawn while you have her here, or anything that you wanted to add?
Dawne, what did you feel about the kind of length of the program and how we sort of spread it out over a year? Would you think it needs to be kind of changed in terms of length of program?
I liked the length of the program, and I think we had enough time to be able to like learn the skills, like learn the theories and stuff, but also have that time as hands-on practice. So I think it was laid out really well as far as timeline.
Super.
Awesome. Dawn, is there anything else that you wanted to add? I know you're super busy. I appreciate you taking the time out from
Thanks,
you're in
Dawn.
class, right?
Yeah, I am.
Always busy. Yeah, is there
Okay.
anything else you wanted to add, or?
I don't think so. Just the fact that I really think the program has huge potential to be able to reach out to communities and stuff like that, and be able to take it out to people that may not be able to take the time to go to a different place to take the training or have online training and things like that. So I think it's a great opportunity to be able to expand it out to other places because it's a huge need.
Fantastic. Thank you very much for your time, Dawn. I appreciate it.
Thanks, Dawn.
No problem.
Thanks,
Yep,
Dawne.
thank
Take
you.
care.
Bye.
Bye-bye.
Thank you. You too. Take care. Bye.
Okay. So
That
Yeah,
was
that was-
helpful.
that was
That was
very
actually
helpful.
helpful for me to hear about, both that she's still using it was
Mhm.
encouraging, but also I think that was a really good example of context, is that she's saying, it would have been helpful to have, because we came in thinking typically it's the older adult.
yeah.
And typically it's, the fractures, the falls, the strokes. But in her world, and it's a very legitimate case she makes, is that there's a lot of developmental delay cases. There's a lot of circumstances where if they had the rehab skills, it would be really helpful.
Mm-hmm.
Yeah.
Yeah, absolutely. That's the sector of the population that's growing the fastest in these communities is the under 15s, and so it really, I think you're absolutely right. We might very well shift the curriculum to include much more of that, because that's where the need is.
Mm-hmm.
Mhm.
Yeah.
Mm-hmm.
So I have one question from a participant. I think this one is just a little bit more general, so that they can kind of get a sense of the curriculum and kind of what it trains you to do.
Mm-hmm.
If someone were to take this program, right, hypothetically, what is the difference between this programming and something that they would go away to UBC to do PT or OT? Is it just the diagnostic process, or kind of what is the difference between these two programs, or those two programs?
There's sort of 3 tiers. So
Okay.
so the program that we delivered was the certificate level program, which is, in post-secondary language, that's 30 credits.
Right.
It's a 1-year program. But they already had prior learning. So to me that
Yeah.
put them higher than that. The rehab assistant level of training is a 2-year diploma at 60 credits. And they work under the supervision of OTs, physios, and speech language pathologists. So they don't assess. And they don't do the treatment planning, and they don't do the discharge planning. They're basically there to carry out clinical, technical, operational tasks that are assigned to them.
Mm-hmm.
They don't need to be supervised in the sense that someone's standing over them watching them,
Yeah.
but they do need to be able to communicate and report back, because at the end of the day, they're unregulated health professionals.
Yeah.
Whereas physios and OTs and speech language pathologists are regulated, and so they're responsible for the services that are provided.
Mm-hmm.
So then Robin can speak to the physio OT level of education.
Yeah, so currently in Canada, that is a master's level entry program. So typically students come in with a prior degree, could be in health sciences, or it could be in biomedical, or it could be in kinesiology, and then take a 26-month program to become an occupational therapist or a physical therapist. And that's where they then learn the skills to actually assess pathology, assess injuries, assess the disease process, and be able to prescribe what the treatment is going to be. So it's a much higher level of qualification, but also ability to then be the primary contact in terms of seeing an individual and determining what kind of treatment they need. So if someone was to take this program, and particularly, as Tracy said, if they have a little bit of a background in, being a healthcare aid assistant or that kind of thing, then they're equipped to be able to really just assist an individual with a program that would already have been established. They don't have to make up that program. They don't have to determine what that individual needs, but really they're there to carry out a program that's already been designed. Yeah.
But we did also speak to the fact that we were hoping that within their communities they could have a leadership role in some health promotion activities as well. So, they could be carrying out physio OT services, but they could also be doing some, initiatives that come from them, creating some exercise groups or a walking group. Those things aren't owned by physio or OT, so, they could be done at a community level with that kind of training. Yeah. One thing I'll add is that one would hope that someone who would get this level of training might say, wow, I'd really like to be a physio or an OT, right? And so, unfortunately, in Canada, there's a disconnect. There isn't a natural ladder to go from one level to the next. Right. But informally, just having that exposure and that experience would make them a much better candidate if they wanted to go on with their education.
Yeah. I think that was kind of part of the root of the question there was how can it always, for me, it always relates back to capacity building within community. And I know we spoke, this is fantastic, absolutely, because there, even if you had from each community, even if you had a couple trained physiotherapists that lived and worked and were born in that community and went back there's still too many people for that person to see. So of course you need these support skills in place, right? But that was kind of the root of my question was how would, if someone was to take this and become incredibly interested in it and come back and have an even more kind of far-reaching impact in that community, what would be their steps? But it sounds like they would have to go and probably do a university.
In Canada, that's the way. In some countries, like in the UK, you can actually on-the-job ladder from an assistant into becoming a physio. And some countries do have that model. But we don't have that yet. Our students, after their 2-year diploma, they have to finish a degree, two more years, so they can ladder into that, and then they apply to the master's. Okay. So it can be done.
Great. So I think that kind of brings us to the end. I guess as my kind of final question of the day, what is the future of the program? What are you guys thinking? What are you envisioning? Let me in on your secrets.
Well, we think we have a good model. I think as we've been talking about, I think we believe that this concept of building capacity in community by identifying folks in community that would be interested in being able to provide the rehab activities and services there is the right model. We really think that by partnering with other health organizations, whether that's First Nations Health Authority or whether that's with band councils or whether it's with other providers like Sekani Family Services, if we can build partnerships to be able to support those individuals in community and then give them the skills, I think this training program has the potential to be able to provide those skills and knowledge to those individuals. And then I think we have in place in community someone who can carry that out. And I think, as you say, hopefully over time as we build more capacity for OTs and PTs, then it's easier for them to go to community to be able to provide those services, what we call itinerant services, so as needed or on a frequent basis, but are not there all of time. It's the folks in the community that are there all the time that could then provide more culturally relevant and appropriate services to meet the needs, as opposed to these, fly in, fly out. And I'm one of those drive for 5 hours on the logging road into community, but I'm not there all the time. And what would be just so great is to have someone in community that actually could then carry out that project. Yeah, so I think that's our dream. We really feel that the model is here, and we'd love to work with other organizations and other communities about how to, as Tracy said, sort of identify the need, be able to support the model, and then we'd be happy to actually deliver the curriculum part. That's the fun part, easy part for us, but it needs to come from community more.
So what you'd be looking for are like interested community members, health directors, that sort of thing, that would want to kind of partner with you in bringing this curriculum to their community. That's kind of what we're talking about.
Yeah.
If they have the ability to kind of support the individual on the ground in a way that employs the individual, or has the structure for that individual to do that, then that would be perfect.
Great.
Yeah.
Great. And in terms of, I guess, a personal question of mine, this was a one-time grant that you guys had gotten, so where would the money come to support the curriculum, like in terms of resources, like those toolkits that we had talked about before?
Yeah, good question. So that's the problem, is this isn't, the way we did it isn't sustainable to be offered, quite the same way. This was, a gift that we got to do it this way. And that's why it really was kind of a pilot feasibility. So the students didn't pay tuition, and the communities didn't have to pay for this. It was funded.
Yeah.
It would need to be cost recoverable in future, and whatever means that we did it, which is why we'd need to get a little more creative with perhaps online mixed mode to keep the costs down. But I think that's quite doable too.
Yeah. Yeah, absolutely.
Great.
And with telerehab too, like telehealth, I think we used that too. Yeah.
Yeah, that's a big part, I think, of the service delivery model, that, ideally if there's someone in community, then OTs and PTs can use telehealth to be able to actually support that individual in the community. The OT and PT don't have to be in the community, but they can be there to support that individual.
Yeah. Well, just in if anything, a program like this accompanying something like telehealth improves the efficacy of both of those things, right?
Yeah, absolutely.
Cool. Okay, awesome. So with that, I'm just going to do my brief outro. If you have any questions or comments about the program for Robin, for Tracy, please populate the chat box, send me a little message. I'm watching very intently here. So coming up for the rest of the month of March, we have several cool sessions. Harley Eagle's going to come and join us. We're going to have a chat about cultural safety in the context of many different industries linked by kind of a contemporary event. We're going to have a chat about just all sorts of settings for cultural safety, which should be really, really interesting. We're hoping to have Nadine Karan join us at some point this month from the Northern Biobank Initiative, so watch our website for that one. Denise is going to come join us to highlight her new partnered program, Gathering Our Medicine. So we're very excited for that. That one's next week. So please, if you're interested in that at all, sign up and we'd see you there. Looking over the questions, I think we just did such a fantastic job of answering all of them. We actually just had a question come in: what are the costs for the rehab program? But we kind of just chatted about that in our outro anyway. So as it stands, to summarize, we're not sure what the cost would be moving forward. I think it would depend on the community that partnered with the project, I guess, with the Rehab Skills project. But for the first go round, there was no cost to the individuals. That's correct.
That's
yeah.
Right, yeah.
Yeah.
And I would, if I may say, I mean, I think we've developed the curriculum and we've developed the program. So a lot of that work, there's certainly putting it online and doing a few other things that we would probably need funding for. But I think, the basis of it's there.
Yeah. It only needs a little bit more. Push it. You know what I mean? Push it online.
Right.
Exactly. Cool. So I just wanted to take a moment out. Thank you both very much.
Thank you.
Thank you for the opportunity. Thank you.
I had a really great time, and I feel like I've expanded my knowledge quite a bit about, in particular, the way that that rehab is carried out in community. I think I had a slightly skewed idea as to like how that actually happened. So thank you very much for clearing that up for me.
That's cool.
And we'll have to send Dawne our thank you as well.
Absolutely. Yes.
Until next time, everyone that was watching at home, take care, and we'll see you soon.
Thank you all.